everyone, this is Morgan Brockington, and I will be presenting on bacterial vaginosis for Nursing 601 Advanced Pharmacotherapeutics. For our case study today, we have Megan, a 26-year-old female who presents at the clinic with a fishy vaginal odor and a thin grayish discharge that began 2 days ago. She states that she had unprotected sex with a new partner the day before her symptoms began. She denies dysuria or pruritus and states that she tried douching but that didn't help her symptoms. She has no prior medical history and no pertinent family history. She is single, lives with one roommate, and drinks 2 to 3 glasses of wine on weekend nights. She's also sexually active and typically uses condoms. She has no known drug allergies and has a Mirena IUD. On physical exam, a homogeneous, frothy, grayish-white discharge and fishy odor are noted. These are characteristic of bacterial vaginosis. The AMSL diagnostic criteria may be used to confirm this diagnosis. 3 of these criteria must be present: a thin grayish vaginal discharge, a pH greater than 4.5, a positive whiff amine test, and greater than 20% clue cells on saline wet mount. However, for this case, AFFIRM testing is used to confirm the diagnosis. The AFFIRM microbial identification system is a molecular system for the detection of vaginitis. It uses DNA probe technology to accurately and quickly identify Candida species, Gardnerella vaginalis, and Trichomonas vaginalis. Traditional methods for the detection of vaginitis, such as microscopy, gram staining, and culture, are subjective. These methods are also shown through repeated studies to be low in sensitivity and specificity, and highly demanding on clinic staff. The AFFIRM system helps solve these problems and provides results in less than 1 hour for quick diagnosis and treatment. In the case of Megan, a high concentration of Gardnerella vaginalis was identified to confirm the diagnosis of Gardnerella vaginitis, otherwise known as bacterial vaginosis. Bacterial vaginosis is a type of vaginal inflammation caused by the overgrowth of bacteria that is naturally found in the vagina. Women in their reproductive years are most likely to get bacterial vaginosis, but it can affect women of any age. The cause isn't completely understood, but certain risk factors, such as having a new sexual partner, having multiple partners, or frequent douching, have been identified. In our case study, Megan is a 26-year-old female. She is single and she has recently had a new sexual partner. For these reasons, she is at a higher risk for bacterial vaginosis. Treatment is indicated for all symptomatic women with bacterial vaginosis. The purpose of treatment is to relieve vaginal symptoms, reduce signs of infection, and potentially decrease the risk of HIV or other STIs. Treatment options differ somewhat between pregnant and non-pregnant patients. For non-pregnant patients, oral metronidazole, vaginal metronidazole, or vaginal clindamycin may be used. For pregnant patients, only the oral formulations of metronidazole and clindamycin may be used. For this reason, I would want to rule out the possibility of pregnancy in Megan. The drug of choice for both pregnant and non-pregnant patients is metronidazole. Oral and vaginal formulations have equal efficacy, thus the choice depends on patient compliance and preference. In the case of Megan, she has expressed preference for oral metronidazole. For persistent or recurrent cases of bacterial vaginosis, other treatment options exist. For non-pregnant patients, metronidazole 0.75% intravaginal gel should be used twice weekly for 4 to 6 months. In pregnant patients, oral metronidazole 500 milligrams should be used twice daily for 7 days. Emerging treatments for bacterial vaginosis, such as vitamin C vaginal tablets and secnidazole oral granules, are currently being explored. Vitamin C vaginal tablets, however, have shown little evidence of efficacy and need more long-term studies. The FDA has approved secnidazole As a single-dose treatment, however, more evidence is also needed for this option. The treatment option I chose to explore further was oral metronidazole, which is dosed at 500 milligrams twice a day for 7 days. Metronidazole belongs to the drug class of nitroimidazole antibiotics. It works by disrupting DNA and protein synthesis and is most useful against anaerobic bacteria. In our case, it is being used against Gardnerella vaginalis. After oral administration, it is absorbed 80% by the body. It is widely distributed into the tissues and fluids, including the cerebrospinal fluid. It crosses the placenta and enters fetal circulation rapidly, as well as enters breast milk in concentrations equal to plasma. It is partially metabolized by the liver, 30 to 60%, partially excreted unchanged in the urine, and is eliminated 6 to 15% in the feces. Metronidazole has a half-life in children and adults of 6 to 12 hours. It has a rapid onset, a peak duration of 1 to 3 hours, and a total duration of 8 hours. Common adverse side effects of metronidazole include dizziness, headache, GI upset, nausea, vomiting, diarrhea, loss of appetite, constipation, and a metallic taste. As a provider prescribing metronidazole, I would want to be monitoring creatinine at baseline and a white blood cell count with differential both at baseline and after treatment completion. Metronidazole can potentiate the effects of some medications, including Coumadin or warfarin, which are both blood-thinning agents, Propulsid, which is a medication for gastric reflux, lithium, and Mylurin, which is an alkylating agent for patients with chronic myelogenous leukemia. Alcohol or foods that contain propylene glycol should be avoided with metronidazole. There are no adverse reactions to taking vitamins and metronidazole together, however. Metronidazole comes in both a generic formulation and a brand name called Flagyl. There is a large difference in price, and I would recommend the generic version for my patient. The efficacy of oral metronidazole has been established in randomized controlled trials using placebos or active drug controls. It has a high cure rate of 70 to 80% at 4 weeks. Oral medication is more convenient but associated with a higher rate of systemic side effects. Therefore, this must be considered when prescribing this medication. Treatment with a single oral dose of 2 grams has a lower efficacy and is no longer recommended as a treatment option. Patients should not drink alcohol or consume food or medicines that contain propylene glycol while taking metronidazole and for at least 1 to 3 days after they stop taking it. Taking metronidazole in combination with alcohol may have very unpleasant side effects such as headaches, stomach cramps, nausea, vomiting, and flushing. Additionally, patients should not use metronidazole if they have taken disulfiram, also known as antabuse, within the past 2 weeks. Patients should be reminded to complete the full course of prescribed antibiotics, even if their symptoms begin to improve, in order to prevent bacterial resistance. Douching, scented soaps, and bubble baths should be avoided in order to prevent bacterial vaginosis. Treatment of male sexual partners is not necessary. However, consistent condom use is advised to reduce the rate of recurrence. Thank you very much for your time and attention. You will find my references used below.